Welcome to the weekly Neurology Deep Dive, produced by Amara Gavanini. Today we are dissecting one of the most challenging and frankly common conditions in general neurology, functional neurological disorder.
And before we embark on this analysis, it's essential we state the crucial mandatory disclosure. This discussion is intended solely for educational purposes. It has no commercial goal, and it serves strictly as a summary of the source material. We strongly recommend all listeners read the full source papers to gain a comprehensive understanding.
Our mission today is really quite practical. We're aiming to synthesize the most advanced thinking on the pathophysiology of functional neurological disorder, specifically focusing on the active inference model. The goal is to help you, the practicing neurologist, not only grasp the how, but also to gain better tools, better language to communicate this mechanism effectively to your patients.
Let's begin with the hard numbers. They really define the clinical reality we're dealing with. Functional neurological disorder isn't some rare entity. It's exceptionally prevalent. The reported incidence is somewhere between 10 and 22 per 100,000 people each year.
And the prevalence?
Prevalence ranges from 80 up to 140 per 100,000. These figures confirm that nearly every general neurologist, regardless of their specific subspecialty focus, is encountering these patients on a regular basis.
And that high prevalence is coupled with a significant financial burden, isn't it? The literature consistently points this out. This condition is profoundly costly, not just in terms of lost productivity for the patient, but also in direct medical expenditure.
That's right. And critically, a substantial portion of that expense seems to be wasted on inappropriate, often repetitive investigations. Think imaging, labs, various electrophysiology studies, all yielding no structural findings.
Which not only drains healthcare resources, but can potentially cause iatrogenic harm, too. It can reinforce the patient's anxiety that maybe something serious, something structural, was overlooked.
And that brings us directly to the communication gap. This is arguably one of the most critical failure points in current clinical practice. Consider this finding. A 2024 survey involving 580 patients revealed that a staggering majority felt, unsupported when they received their diagnosis.
How unsupported?
Only 10% strongly agreed that their neurologist had clearly explained functional neurological disorder at the time of diagnosis. Almost half actually disagreed with that statement.
That statistic is quite sobering. It feels like a call to action, really. When we can't effectively explain the mechanism behind the symptoms, we risk perpetuating those historical and often harmful misunderstandings. The idea that these symptoms are somehow all in their head, or worse, reflect malingering.
Exactly. Our patients are often scientifically curious. They're looking for explanations that validate the very real, very involuntary nature of their symptoms. They want a neurological how and why.
And that's precisely what the Active Inference Model aims to provide. It offers a robust, neurobiologically grounded framework that moves us beyond vague psychological labels. It details a potential pathway from trigger to symptom.
And by understanding this framework, we can potentially offer a more compelling, mechanism-based explanation. We know from clinical experience and research that providing such an explanation is often a vital first step towards improving prognosis and guiding successful rehabilitation strategies.
Okay, let's dive into the core theory itself.
Yeah.
We're focusing on the active inference model because currently it's considered the prevailing and perhaps best established neurocognitive framework for explaining functional neurological disorder. Though naturally, like any complex biological model, it's constantly being refined and debated.
The first step is a fundamental shift in how we view the brain. The core premise here is that the brain isn't just a passive receiver. It's not simply waiting to react to sensory stimuli coming in from the world. Instead, it's a prediction machine. It is perpetually generating, testing, and then refining predictions about the environment and, crucially, about the body's own internal state.
And why operate this way? What's the advantage?
Efficiency and survival, essentially. The brain operates under pretty strict constraints of energy budgeting. Constantly reacting anew to every single stimulus would be metabolically incredibly expensive.
So by predicting what's likely coming next.
Exactly. By predicting, the brain can regulate physiology more smoothly, anticipate upcoming events, and ensure survival with minimal computational cost. It functions, in essence, as a statistical inference machine, often described as Bayesian.
So these predictions, they're based on past experience.
Yes, generated based on literally decades of accumulated prior experiences. These form an internal model of the world. The process then becomes a constant comparison, a contrast between that internal prediction and the incoming sensory reality.
So the brain generates a prediction what the model calls a prior belief and then immediately checks it against what's actually happening.
Precisely. It sense checks this against the incoming environmental or bodily information.
And this happens at different levels in the brain.
Yes, it operates across what's called a predictive hierarchy. These predictions, these representations, they flow top-down. They're typically diffuse, low-dimensional signals traveling from higher-level cortical structures, think prefrontal cortex, parietal cortex, down towards lower levels that handle the raw sensory input.
And the mismatch, the error.
The resulting errors, conversely, travel bottom-up from lower sensory areas back up the hierarchy. The net result, what we ultimately perceive, isn't a perfect mirror of objective reality. It's a posterior belief, a subjective inference shaped by both the prior and the sensory data.
Okay, for this to be useful clinically, especially when talking with colleagues or potentially patients, we need to be precise with our language. Let's define some key terms within this active inference model, starting with the foundation: belief, prior, or prediction.
It's vital to remember these terms are often used interchangeably in the literature. And importantly, they refer to implicit, often pre-conscious models of the world. They're quite distinct from our everyday, rational, conscious thoughts or beliefs.
Got it. Next, the engine driving the system towards efficiency, the prediction error.
This is simply the mismatch. It's the difference generated when the brain's prior belief, its expectation, does not align with the incoming sensory information, the reality signal, if you will.
And the brain doesn't like this mismatch.
No. The entire purpose of this active inference system is to minimize this prediction error, to reduce what the literature terms surprise. Surprise, in this specific context, is metabolically costly. It indicates a failure or inaccuracy in the brain's internal model of the world.
So when a prediction error is generated, how does the brain minimize that surprise and update its model?
Well, fundamentally, it has three main ways to do this. The first, and perhaps most obvious, is to change the prediction itself, to essentially change its mind or update the prior belief based on the new evidence.
Makes sense. What's the second way?
The second way is to change the incoming sensory sampling. This usually involves taking an action, moving our eyes to get a better look, moving our body, shifting our attention, all aimed at gathering better, less ambiguous data that might either confirm the prior or force an update.
Okay, update the belief or change the sampling. What's the third option?
The third method, which is equally important, is sometimes to simply ignore the error. If the incoming sensory information is deemed too noisy, unreliable, or just unimportant, what the model calls having low precision tax, the brain might discard it rather than waste energy updating its model based on potentially flawed data.
That brings us to precision and gain. You mentioned precision. How is that defined here?
Precision defines the reliability or the certainty the brain assigns to any given signal, whether it's a prior belief or incoming sensory data. If the environment is dark or the sensory input is highly ambiguous, that signal has low precision. If it's clear, unambiguous, it has high precision.
And gain, or weighting.
Gain, or weighting, refers to the excitability of the neuronal populations that are encoding these predictions and the prediction errors. You can think of it like a volume dial the brain turns. It decides how much weight or influence to give to a specific signal.
So if an error signal is deemed important,
If the brain decides a prediction error has high precision, it increases the gain on that error signal, effectively amplifying it to ensure it drives an update of the prior belief. Conversely, and this is crucial for functional neurological disorder, if the system assigns inappropriately high precision to a fixed prior, like a rigid illness belief, it can drastically reduce the gain applied to contrary sensory inputs. It effectively ensures the prior belief doesn't get challenged by reality.
okay, let's shift to motor control, terms related to action, efference copy, or corollary discharge.
Right, this is the internal prediction the brain makes about the sensory consequences of a movement before that movement even begins. It's the brain essentially telling itself, I'm about to move my arm like this, and I expect to feel this specific sensation or resistance.
And that prediction allows for sensory attenuation.
Exactly. Sensory attenuation is a necessary, completely normal process where the brain actively reduces or dampens the sensation generated by our own self-mediated actions. When you pick up something light, your brain predicts the movement and the expected light touch, and it attenuates those predictable sensory signals.
Why do that?
It ensures our movements feel smooth and effortless, and it prevents us from being constantly overloaded by the sensory feedback generated simply by moving our own bodies.
And finally, within this set of terms, agency.
Agency is that subjective awareness, that feeling that an action is initiated and controlled by ourselves. It arises when the brain's prediction, the efference copy, closely matches the actual incoming sensory feedback from the movement. When the prediction error is minimized, we get that seamless sense of self-control.
Let's try to make this more concrete with those classic examples. The motor one first, the cup example.
Right. You reach for a coffee mug, assuming it's full. That's your high-precision prior belief, heavy cup. When you lift it and it's unexpectedly empty, a significant prediction error is generated. The amount of effort you exerted doesn't match the expected sensory feedback. Lack of weight.
What happens then?
This large error forces an immediate preconscious motor reprediction. Your arm might overshoot slightly, you might wobble for a fraction of a second, but within milliseconds the prior is updated to light cup and your very next motor command is automatically adjusted. It demonstrates the system's incredible speed and preconscious adaptability in minimizing surprise.
Okay, now the perceptual example, the checkerboard illusion.
Yes, Adelson's checkerboard.
Hmm.
Even when we consciously know that squares A and B are physically the exact same shade of gray, we can't help but perceive them as different. A looks dark, D looks light. Because the brain has an incredibly strong prior belief based on the surrounding context, the pattern of the checkerboard, the implied shadow cast by the cylinder. This prior expectation about how light and shadow work completely overrides the immediate sensory reality, the actual wavelengths of light hitting your retina from those two squares.
So what we perceive isn't the raw input.
It's the inference. It's the brain's best guess, heavily biased by its prior beliefs. This powerfully illustrates the core philosophical takeaway here. Perception is subjective. And if the brain can essentially generate a false visual reality based on strong priors, it can theoretically also generate a false motor reality or a false sensory reality, even when the underlying structural anatomy is perfectly intact. This really lays the groundwork for explaining functional neurological disorder within this framework.
Okay, so we've laid out the general principles. Now let's pivot specifically to the pathology. How is functional neurological disorder proposed as a disorder where these active inference networks break down?
The thinking is that the core pathophysiological disruption involves a combination of factors, really two interconnected elements. First, patients seem to preconsciously attend to aberrant, often abnormal, and crucially overly precise predictions, what we might call a rogue prior.
And the second element.
Second, they appear to have poor quality sensory feedback. This includes not just external sensory information, but also interoceptive information signals about the body's internal physiological state. This poor quality feedback makes it much harder for the brain to generate a strong enough error signal to effectively challenge that rogue prior.
So going back to the checkerboard illusion analogy.
Imagine the patient has developed an incredibly precise, fixed prior belief, like my leg is weak or my leg cannot move properly. Their normal daily movements might actually provide sensory inputs indicating the leg can move, perhaps implicitly. But these inputs are either too noisy, assigned too low a precision, or perhaps ignored because attention is elsewhere, so they fail to overcome that powerful, fixed prediction of weakness.
And this illness belief, this strong prior, takes hold.
Yes, it dominates the system. And crucially, this prior provides an explanation, a reason, for the physical symptoms the patient is experiencing. By providing an explanation, it helps resolve what would otherwise be a very uncomfortable state of uncertainty or surprise for the brain. This very resolution paradoxically strengthens the prior, making it more resistant to change. And this entire process underlies the patient's subjective experience of involuntariness.
How does such a rogue prediction actually form in the first place? Do they just appear spontaneously?
They rarely seem to appear in a complete vacuum. Often they are triggered by something. Consider the example given in the source material. A patient recovering from a physical injury, maybe a road traffic accident.
What happens in that situation?
Initially, the trauma itself puts the brain into a state of high alert, a hypervigilant state. This demands a lot of attentional resources and energy. Subtle, perhaps even normal post-concussive symptoms, maybe some transient confusion, moments of cognitive slowing, or just significant fatigue might receive disproportionately high attention. Because in this high-threat context, the brain classifies these subtle deviations as highly salient, potentially important prediction errors. This heightened attention then starts to reinforce a preconscious prediction of ongoing injury or dysfunction. My brain is damaged, or something is wrong with my thinking.
So the patient starts monitoring themselves more closely.
Exactly. They might start acutely monitoring normal cognitive slips, forgetting a name momentarily, misplacing keys, things we all do. But these normal errors are now filtered through this newly forming prior belief of underlying damage. This focused attention effectively increases the gain applied to any error signal that seems to confirm the illness belief, creating a kind of positive feedback loop that progressively strengthens the prior.
And this is where external factors, including medical interactions, can sometimes inadvertently make things worse.
Precisely. The potential consequence of external reinforcement specifically, things like undergoing extensive medical investigations which all come back negative, followed by perhaps vague or unconvincing reassurance, can unfortunately solidify that rogue prediction. Well, imagine a patient endures multiple brain scans, nerve conduction studies, blood tests, only to be told, "We can't find anything structurally wrong, you seem fine." Yet, their severe functional symptoms, the weakness, the tremor, the seizures persist.
They'd naturally worry something was missed.
Exactly. They worry a subtle structural injury was overlooked. This creates a state of uncomfortable uncertainty. Why do I feel this way if all the tests are normal? The brain seeks to resolve this uncertainty. And often, the most available, energetically efficient explanation is to double down on, to strengthen that initial fixed prior of illness. The illness belief becomes the most stable explanation available to the patient's Bayesian brain, paradoxically reinforced by the negative investigations.
So the active inference model suggests this breakdown involves several interconnected domains.
Yes, the current literature suggests this failure point is multifaceted, but it consistently seems to involve interconnected changes across roughly 4 main domains: shifts in attention, disruptions in the sense of agency, alterations in emotional processing, and changes in sensory processing, including that crucial internal sense, interoception. We really need to delve into the specific disruptions proposed in each of these domains now.
Okay, let's tackle the first major disruption area, attention, and specifically how it seems to inappropriately influence the weighting or precision of signals in functional neurological disorder. Normally, attention is flexible, right? It allows us to switch priorities between taking action and perceiving the world.
That's right. And this flexible toggling is facilitated by sensory attenuation of whichever modality isn't currently the priority.
Can you give an example?
A classic example is during saccadic eye movements, those quick jumps our eyes make. Your brain predicts the visual smear and the sensation of your eye muscles moving, and it actively attenuates or dampens down that predictable feedback. This prevents the world from appearing blurry or jerky every time you shift your gaze. It smooths out perception by canceling expected prediction errors.
And in functional neurological disorder, this balance is somehow disturbed.
The model proposes that the normal, flexible control of attention and sensory attenuation is disrupted. Attention becomes overly focused, often internally, and the precision assigned to certain signals, particularly the internal prior belief about illness, becomes excessively high and rigid.
But attention is modifiable, isn't it? That seems key therapeutically.
Absolutely crucial. This explains, at least in part, why various therapies can be effective, whether it's certain medications that modulate attention networks, cognitive behavioral therapy approaches that train attentional control, specific physical therapy techniques focusing on automatic movement, or even methods like clinical hypnosis. They all, in different ways, attempt to shift that maladaptive attentional spotlight.
The goal being to
reduce the excessive gain or precision assigned to those maladaptive prediction errors or priors, and essentially relax those overly rigid fixed beliefs. This allows the brain the possibility of learning a new, more adaptive internal model.
This connects directly to the difference between implicit and explicit movement control, which seems central to understanding many motor symptoms in functional neurological disorder.
Yes, we all operate with essentially 2 motor systems. Explicit movements are those we consciously initiate and control. They tend to be slower, require more effort, and can often feel clumsy, especially if we're learning something new or focusing too hard.
Like learning to drive a manual car.
Exactly. Whereas implicit movements are automatic, largely unconscious, effortless, and fluid. Think about an experienced driver changing gear, or just walking across a room without thinking about the mechanics of each step.
And in functional neurological disorder, there's a shift.
The model proposes a distinct and inappropriate shift away from the smooth, efficient implicit motor programs towards the slow, effortful, and often jerky explicit motor programs. This occurs because the patient directs excessive attention towards the movement itself, constantly monitoring it.
And this excessive monitoring directly explains that classic clinical sign of motor inconsistency.
Precisely. It's why a patient might often perform a relatively complex automatic implicit task, quite normally like spontaneously bracing themselves if they lose balance, or perhaps climbing onto the examination couch without apparent difficulty. Yet they find it impossible to execute a simple, direct, explicit movement when asked, like moving that same limb against minimal resistance when their attention is fully focused on the task.
It's similar to the analogy of the athlete who chokes under pressure.
It's a very apt analogy. When a highly skilled golfer, tennis player, or musician starts excessively monitoring the mechanics of an action that is normally automatic and overlearned, their performance often collapses. The movement, which should be smoothly handled by highly efficient implicit, perhaps subcortical circuits, gets hijacked by the slower, more cumbersome explicit control systems, likely involving frontal lobe circuits.
So framing this in active inference terms.
Excessive monitoring of the movement dramatically increases the precision, the gain, the weighting assigned to the incoming sensory feedback related to that specific movement. This is the exact opposite of the sensory attenuation that's required for smooth, fluid, automatic action.
Instead of dampening the predictable sensory feedback.
The brain amplifies it. It amplifies any minor prediction errors generated by the movement itself, tiny deviations from the expected trajectory or sensation. This forces the system into a continuous, effortful cycle of error detection and correction, which manifests clinically as that characteristically clumsy, jerky, hesitant, or sometimes described as robotic gait or movement pattern.
This model provides a powerful way to explain to patients that this inconsistency isn't deliberate.
Absolutely. It provides a neurobiological framework to explain that the inconsistency is actually an unfeignable biomarker of the underlying attentional dysfunction. It confirms the symptom is mediated by this inappropriate attentional focus hijacking the motor system, not by conscious deception. Because, crucially, when their attention is successfully diverted, perhaps by a dual task or a clinical trick like Hoover's sign, the underlying implicit motor program, the brain's true capacity for that movement is often preserved and can execute automatically.
Okay, shifting from motor control to a more cognitive style, the evidence suggests patients with functional neurological disorder tend to form fixed beliefs very rapidly. This jumping to conclusions bias.
Yes, this has been demonstrated experimentally, most notably using the bead task. This task measures probabilistic reasoning under conditions of uncertainty. Participants see beads drawn, one by one, from one of two jars, which contain different proportions of colored beads, and they have to decide which jar the beads are being drawn from.
And the finding.
The key finding was that patients with functional neurological disorder required significantly fewer pieces of evidence, fewer beads drawn compared to control participants, before they made a definitive, fixed probability judgment about which jar was being used. They jumped to a conclusion much faster, even when more evidence, potentially disconfirmatory evidence, is still available.
What's the implication of that cognitive style for symptom development?
It's potentially profound. A patient experiencing some initial, perhaps ambiguous somatic symptoms, maybe a brief spell of dizziness, some transient muscle tingling or weakness might, due to this cognitive style, rapidly form a fixed, high-precision prior belief. This is something serious. This is a fixed illness. It represents perhaps a quick shift from more flexible, voluntary, goal-directed thinking towards a more automatic, habitual, fixed belief state.
And this rapid inferential leap might actually serve a purpose initially.
It might resolve the uncomfortable internal state of uncertainty caused by the ambiguous symptoms. By quickly establishing a maladaptive somatic prior, I have this specific condition, the uncertainty is reduced, even if the belief itself is harmful long-term.
And once that fixed belief, that prior, is established,
the system seems to become rigid. Follow-up studies suggest that once the fixed prior is in place, patients then become slower or less efficient in processing subsequent sensory information, particularly information that might challenge that prior. The cognitive resources needed to absorb, evaluate, and integrate new, potentially conflicting data seem diminished. This makes it even less likely that the established fixed prior will be updated or revised by ongoing experience.
This seems consistent with a clinical observation that patients can sometimes be more responsive to hypnotic suggestions.
It does seem consistent. That increased suggestibility could reflect this underlying readiness to form fixed priors, perhaps particularly in response to external influences or cues. When faced with high internal uncertainty or ambiguity, the brain might more readily take an inferential leap, adopting an externally provided explanation or suggestion, whether that suggestion is ultimately therapeutic, as in structured hypnosis, or maladaptive, like internalizing a fear or a specific belief about physical injury based on limited evidence.
So we've established this idea of a rapidly formed, overly precise, and rigid prior belief, often fueled by misdirected attention. The next logical consequence seems to be a failure or disruption of the sense of agency. Let's explore how this mechanism leads to the patient's core subjective experience, that the symptom, the movement, is entirely involuntary.
Exactly. The sense of agency, that feeling of being in control of our actions, is proposed to be disrupted when there's a significant, persistent, and unresolved gap, a prediction error, between what the brain expects to happen during a movement, the prior prediction or efference copy, and what actually happens, the resulting perception or sensory feedback from the movement.
And because the prior is so rigid.
Because the prior belief is so fixed and resistant to updating, this prediction error doesn't get resolved. The mismatch persists. This ongoing unresolved error signal means the brain loses that crucial subjective awareness that the action originated from or is currently being controlled by the self.
We know the prior is fixed, but why is it so resistant to change, especially in the motor domain? We've mentioned the attentional focus, but are there other factors?
Yes, besides the fixed attentional spotlight we discussed, impaired prior updating mechanisms and potentially poor sensory data quality seem to conspire to trap the patient in this cycle of maladaptive inference, making the prior incredibly stubborn.
Is there objective evidence for this impaired prior updating in motor control?
Yes, the Travelator study provides really compelling objective evidence here. In this experiment, patients with functional gait disorder, alongside healthy controls, were asked to walk on a moving platform, essentially a large treadmill or travelator.
And they could adapt to it.
Yes, both patients and controls successfully adapted their gait pattern to maintain balance while walking on the moving platform. This suggests that when their attention was effectively diverted to the novel motor challenge of staying upright on the moving surface, their motor system could learn and adapt, at least temporarily.
So what was the critical finding?
The critical phase came afterward. When participants stepped off the moving travelator back onto a stationary platform, the patients with functional neurological disorder were significantly and persistently slower to readapt their gait back to normal walking on a stable surface compared to the controls. They showed a much more pronounced and longer-lasting locomotor after effect.
What does that demonstrate?
It elegantly demonstrates a failure of this system to rapidly update the motor prior. The strong prior belief representing the abnormal gait pattern that was necessary for the moving platform persisted. It was resistant to be immediately overturned by the new, clear sensory input from the stationary floor. The brain's motor model essentially got stuck on the recently learned but now maladaptive prior.
And you mentioned the quality of sensory data itself might be impaired?
Yes, compounding this difficulty in updating priors is evidence suggesting the quality of the incoming sensory information might be degraded or processed less efficiently. Objective cognitive testing often shows that patients with functional neurological disorder display persistently slower reaction times and reduced accuracy, particularly as task complexity increases.
Is this just general slowness or something more specific?
It appears to be more specific. This finding has been quantified using computational modeling, specifically the drift diffusion model. These analyses estimate a parameter called the drift rate, which essentially represents the speed or efficiency with which a decision-making system accumulates sensory evidence towards a decision threshold.
And in functional neurological disorder?
Patients consistently show a reduced drift rate across various tasks. This provides quantitative evidence that the quality of the bottom-up sensory feedback might be poor. The reality signal, if you like, is perhaps too weak, too noisy, or accumulates too slowly to effectively challenge and overcome the powerful, fixed top-down prior prediction.
Okay, so we have a fixed prior, difficulty updating it, and possibly weak sensory input challenging it. How does this translate into measurable changes in the subjective feeling of agency?
That subjective experience of involuntariness, the loss of agency, can indeed be probed and objectively measured in experimental settings. One example is the intentional binding effect, sometimes called action effect binding.
How does that work?
In healthy individuals, when you perform a voluntary action, like pressing a button that is predictably followed by a sensory consequence, maybe a specific tone, your subjective perception of the time interval between your action and the resulting tone is compressed. The action and its effect feel closer together in time than they actually are. This temporal binding is considered a proxy measure for the strength of the feeling of agency.
And in patients?
Patients with functional neurological disorder typically show a reduced intentional binding effect. The perceived temporal link between their voluntary action and its sensory outcome is weaker. The action and effect feel further apart in their subjective experience, indicating a reduced sense of agency over the action's consequences.
Is there other evidence for this reduced awareness, particularly around the intention to move?
Yes. Studies using the classic Libet clock paradigm reinforce this. This paradigm measures the precise timing of a subject's conscious awareness of their intention to make a movement, often labeled W time for will, relative to the timing of the actual movement onset, M time.
What do these studies show in functional neurological disorder?
They consistently find that the temporal gap between the awareness of intention and the actual movement initiation
Yeah.
is significantly reduced in patients with functional neurological disorder compared to controls. The awareness of wanting to move occurs much closer in time to the movement itself.
What does that imply?
It reflects a diminished conscious awareness of the intention prior to moving. This is a key early component of the normal sense of voluntary agency being disrupted. The patient is, in a sense, truly robbed of that conscious preparatory spark, that feeling of, I am about to move.
Is there a neural correlate for this?
Yes, importantly, this reduced interval between intention awareness and movement was found to be associated with lower activity in the inferior parietal cortex. This brain region is known to be heavily involved in motor planning, intention formation, and that subjective feeling of wanting to move. This neurobiological finding strongly supports the patient's subjective report that it just happens, seemingly without prior intent.
Let's come back to sensory attenuation. You mentioned earlier it's reduced in functional neurological disorder. How is that shown?
Right, we discussed how healthy controls typically cannot tickle themselves effectively because the brain predicts the sensory consequences of the self-touch and attenuates the resulting sensation. Studies suggest patients with functional neurological disorder lack this normal sensory attenuation during self-generated actions.
What do the experiments involve?
One clever paradigm involved asking subjects to apply a certain amount of pressure to their own fingertip. They did this either directly with their other hand or indirectly via a robotic arm, which was programmed to apply the exact same pressure they intended.
And the results?
Healthy controls, due to sensory attenuation canceling out some of the self-generated sensation, actually pressed harder on their own fingertip when applying the pressure directly compared to when the robot applied it externally. They needed to press harder to achieve the same perceived pressure level.
But patients with functional neurological disorder.
Patients with functional neurological disorder did not show this difference. They perceived the self-generated pressure as being just as strong as the externally generated pressure. This reflects a failure of the brain's predictive mechanism to anticipate and cancel out the sensory consequences of their own actions, providing further objective evidence for reduced agency and altered sensory processing.
Does this altered prediction and agency extend to how patients perceive their own body's form? You mentioned body schema alterations.
Yes, there's evidence for that too. Studies using tasks like the forearm bisection task, where patients have to judge the midpoint of their own unseen forearm, show that patients with functional neurological disorder often exhibit a consistent proximal bias. They tend to perceive their arm as being shorter than it objectively is.
What does that suggest?
It suggests a potential disruption even at the level of the resting state body schema, the brain's internal map of the body's configuration. This might be due to the chronic lack of updated, reliable sensory information, or the dominance of an aberrant prior about the limb. When these patients are tested with perceptual illusions that normally require integrating new sensory information to update the body schema, like the rubber hand illusion, they often show altered responses, perhaps reflecting their difficulty in overriding the previous, potentially maladaptive, fixed prior about their body.
Okay, so we have these converging lines of evidence pointing to disrupted agency. Is there a specific brain region implicated as being central to this breakdown?
Yes, the right temporoparietal junction is widely considered to be a crucial node within the brain's agency network. It's often referred to as a kind of master comparator. Its proposed function is precisely to integrate the prior prediction about an action, the efference copy, with the actual sensory feedback resulting from that action, the reality.
And what does functional brain imaging show regarding the temporoparietal junction in functional neurological disorder?
The functional magnetic resonance imaging data focused on this area provides arguably some of the strongest objective evidence we have for the biological basis of involuntariness in functional neurological disorder. The key studies used a within-subject design comparing brain activity during a patient's real involuntary functional tremor versus activity when the very same patient was deliberately feigning or mimicking their tremor.
Oh, what is the difference?
The critical finding was that the right temporoparietal junction was significantly hypoactive, less active during the episodes of genuine functional tremor compared to when the patient was intentionally feigning the tremor.
That seems incredibly important.
It really is a cornerstone finding. During the feigned tremor, the comparator region was active. The brain was registering the match between intention and action. The patient knew they were doing it. But during the genuine functional symptom, that comparator region was relatively silent or hypoactive. This suggests the brain was failing to correctly compare the prior prediction with the reality, failing to generate that signal of self-agency. It's a powerful neural demonstration of a true loss of self-awareness and control during the symptom, the very essence of involuntariness.
Does this localization offer any therapeutic possibilities?
It certainly does. The fact that we have this relatively robust localization points towards potential therapeutic targets. Indeed, early pilot studies using non-invasive neuromodulation techniques, such as repetitive transcranial magnetic stimulation, or specifically theta burst stimulation, targeted directly at the right temporoparietal junction, have shown some promising initial results in reducing symptoms, perhaps by resetting or recalibrating the function of this crucial master comparator region. We now need to address the third major domain of disruption, the powerful entanglement of the emotional system. This provides critical context for understanding why functional neurological disorder often develops, sometimes emerging many years after an initial trigger or adverse event. We know from extensive research that adverse life events, particularly chronic adversity or trauma during childhood, are highly prevalent in the patient population.
And this history of adversity leaves a measurable mark on the brain.
Yes, the evidence suggests this sustained adversity can leave a palpable neurological footprint. Key brain areas deeply involved in emotional processing, most notably the amygdala, often display significant alterations in patients with functional neurological disorder. They frequently show hyperactivity, an exaggerated response to emotional stimuli.
And it's not just hyperactivity within the amygdala itself.
No, it's also about connectivity. These emotional processing centers, like the amygdala, often show increased functional interconnectedness with other crucial regulatory networks. This includes links to motor control systems, the stress response system via the hypothalamic pituitary adrenal axis, the salience network, which detects important stimuli, and even the central executive network involved in cognitive control.
What does that increased connectivity imply?
It suggests a chronically heightened salience or importance assigned to emotional and stress-related events. It might create an underlying state of hyperarousal or hypervigilance. This state, potentially sustained by dysfunction in the hypothalamic pituitary adrenal stress axis regulation, could increase the overall level of prediction error signals within the entire system, making the brain more vulnerable to adopting and maintaining a maladaptive prior, such as an illness belief.
Is there a proposed mechanism linking this chronic emotional distress more directly to the physical symptoms, particularly motor symptoms?
Yes, the concept of the limbic motor fast track has been proposed. Several functional imaging studies have demonstrated increased functional connectivity, stronger communication pathways between specific limbic areas like the amygdala and specific motor control areas like the supplementary motor area in at least some subgroups of patients with functional neurological disorder, particularly those with motor symptoms.
What does this fast track allow?
This altered wiring essentially means that the brain networks responsible for voluntary movement initiation and the sense of agency can be powerfully and inappropriately influenced or even hijacked by emotional interference, especially during times of stress or heightened emotion.
Is there specific evidence for this connection?
For instance, one study observed increased functional connectivity, specifically between the right supplementary motor area and the right amygdala in patients while they were performing tasks involving emotionally charged stimuli. This suggests a hyperreactivity where emotional inputs seem to immediately spill over and directly influence activity in motor planning regions.
And is there also evidence for problems with top-down control over these emotional influences?
Yes, complementing this, other research has indicated potential dysfunction in top-down regulation from prefrontal areas. For example, the left supplementary motor area showed lower functional connectivity with bilateral dorsolateral prefrontal cortices in patients.
What might that mean functionally?
This can suggest that previously established conversion motor representations, which are essentially a type of maladaptive motor prior or habit, might be more likely to hijack the voluntary action selection system, precisely because the frontal lobes, which normally provide inhibitory control and top-down regulation, are effectively disconnected or less able to exert control, particularly in emotionally salient or stressful situations.
This idea of a hardwired limbic motor link might explain differences in patient outcomes.
It gives rise to the concept of a potential trauma subtype of functional neurological disorder. Patients who have experienced significant childhood or early adult adversity often present with more entrenched symptoms and, critically, seem to have poorer outcomes in standard rehabilitation programs. The early trauma may effectively create a kind of limbic scar, a persistent hyperreactivity that predisposes the individual to this fast-track hijacking mechanism being more easily triggered later in life.
It's also mentioned in the source material that there's an identified overlap with neurodiversity.
Yes, that's an important emerging area. Studies have pointed towards measurable differences or potential deficits in areas like theory of mind, understanding others' mental states, and also in basic sensory processing within populations with functional neurological disorder. Given the observed increased prevalence of functional neurological disorder in individuals who identify as neurodiverse, this suggests that perhaps pre-existing differences in how sensory information is processed, integrated, and interpreted might create a vulnerability or predisposition towards forming and maintaining these kinds of fixed, maladaptive somatic priors.
Okay, let's shift our focus inward now to interoception. Can you define that for us?
Interoception refers to the brain's continuous, moment-to-moment sensing and modeling of the body's internal physiological state. This includes signals from the autonomic nervous system, visceral organs, hormonal milieu, even immune status. Its primary purpose is believed to be allostasis, the brain's ability to anticipate the body's energy needs and efficiently manage internal resources to maintain stability in the face of changing demands.
And where is interoception mainly processed?
The insular cortex is considered a primary hub for processing and integrating these interoceptive signals into a coherent sense of the body's internal state.
And how does interoception relate to functional neurological disorder?
There is growing and compelling evidence suggesting inaccuracies or disruptions in interoceptive processing in functional neurological disorder. Studies have shown evidence of inaccurate perception of internal bodily signals, like heartbeat perception tasks, and also findings of reduced insular activity during tasks that involve processing affective or emotional stimuli.
So the brain's internal model of the body's state might be inherently noisy, biased, or inaccurate.
That's the idea. This potentially inaccurate modeling of internal signals has profound implications, particularly for how emotions are generated and experienced.
How so?
This ties into the constructed emotion theory, which actually aligns very nicely with the broader active inference framework. Instead of thinking of emotions as fixed circuits that get automatically activated by triggers, this theory proposes that emotions are actively constructed or predicted by the brain,
Constructed based on what?
based on a combination of factors: past experiences in similar situations, the current external context, and crucially, the brain's interpretation of the current interoceptive signals coming from the body.
Can you give me an example?
If a particular pattern of internal somatic signals, say a racing heart, shallow breathing, muscle tension, matches the brain's prior prediction or learned model for fear in that context, then the brain constructs the subjective experience of the emotion fear. But, and this is key, if that same pattern of internal signals, perhaps due to inaccurate interoceptive mapping or a different prior belief, fails to get categorized under an emotional label, it might instead be constructed or interpreted as something non-emotional,
Such as?
such as generalized fatigue or brain fog, or perhaps attributed to an unexplained physical illness. The physical sensations are real, but their interpretation and the resulting conscious experience are different.
Does this help explain common clinical observations?
It provides a potential mechanism for the frequently observed phenomenon of alexithymia in functional neurological disorder, the reported difficulty patients have in identifying, distinguishing between, or describing their emotional states. It might also help explain related phenomena like panic without panic, which is sometimes described, particularly in the context of functional seizures.
What happens in panic without panic?
The patient exhibits many of the objective somatic signs we associate with a panic attack: tachycardia, hyperventilation, sweating, but they don't subjectively report feeling the emotion of intense fear or panic. According to the constructed emotion view, the underlying physiological signals are present, but the brain, perhaps due to altered interoceptive inference or strong non-emotional priors, fails to categorize them and construct them into the conscious experience of panic. They're interpreted differently.
What about allostasis, the long-term regulation? Is that linked to specific brain networks?
Yes. The default mode network, which includes key regions like the medial prefrontal cortex and the precuneus posterior cingulate cortex, is thought to play a major role in generating these longer-term allostatic priors, the brain's predictions about maintaining internal stability over time and integrating self-related information.
And abnormalities in the default mode network are seen in functional neurological disorder.
Yes, particularly in relation to dissociative symptoms. Studies have found abnormalities such as increased activity within the default mode network and, crucially, reduced functional connectivity between the default mode network and the salience network, which normally helps switch attention between internal and external focus. These alterations are strongly linked to the profound experiences of dissociation, depersonalization, and detachment from reality that are often prominent features, especially in functional seizures.
Finally, in this section, there's the observation that functional neurological disorder is often associated with variable objective autonomic deficits.
That's correct. There's a well-documented clinical association, or comorbidity, with conditions that involve autonomic nervous system dysregulation, such as postural orthostatic tachycardia syndrome, POTS, and also with complex regional pain syndrome, CRPS, which has autonomic features.
But the objective autonomic findings can be quite variable between patients.
They often are, and they frequently defy simple classification based on standard autonomic testing alone. The literature suggests these variable objective findings are likely multifactorial. They probably stem from a complex interplay of the factors we've discussed: altered limbic system input to autonomic centers, changes in insular function affecting interoceptive processing, chronic dysregulation of the hypothalamic pituitary adrenal stress axis, secondary effects of deconditioning due to immobility or activity avoidance, and the primary alterations in interoception and predictive processing within the brain's internal modeling systems.
Okay, we've explored the different components: attention, agency, emotion, interoception within the active inference model as they relate to functional neurological disorder. Now, for the practicing neurologist listening, it's really vital to consolidate this complex mechanism into a clear, concise, and communicable framework, something we can actually use in the clinic.
Absolutely. Let's try to summarize the key steps that, according to this active inference model, seem to contribute to the clinical presentation of functional neurological disorder. We can think of it perhaps as a sequence, although these processes are likely highly interactive. Step 1. There appears to be a rapid formation of a strong, unusually precise prior belief that jumping to conclusions bias we discussed. This initial formation might be potentiated or influenced by that limbic motor fast track, especially if there's a history of adversity, acting as a filter that prioritizes illness-related interpretations.
Okay, step 1, rapid formation of a fixed prior. Step 2.
Step 2. This fixed prior then demonstrates extreme resistance to change or updating. We saw evidence for this in the persistent after effects in motor adaptation studies, like the travelator task. The patient's internal model becomes rigid, locked into this maladaptive illness belief.
Step 3 relates to the sensory input.
Yes, step 3 involves the potentially poor quality or inefficient processing of incoming sensory information reflected in that reduced drift rate found in decision-making tasks. This means the bottom-up signal from reality, the evidence that could potentially challenge the prior, is too weak, too noisy, or accumulates too slowly to effectively force an update of that strong, fixed, top-down prediction.
Step 4 is the direct consequence for agency.
Step 4 is the resulting reduced sense of agency. This arises from the persistent, unresolved prediction errors between the intended or predicted movement and the actual sensory feedback, combined with the failure in the core agency circuitry, particularly that observed hypoactivity in the right temporoparietal junction. This directly leads to the patient's genuine subjective experience of involuntariness. The symptom feels like it's happening to them, not by them.
And finally, step 5 connects this back to the observable clinical signs.
In step 5, this cascade ultimately results in impaired explicit movement execution and that reduced sensory attenuation. The system shifts away from smooth automatic motor programs and forces control into the clumsy, effortful, attention-demanding explicit mode. This manifests clinically as the jerky, inconsistent, weak, or tremulous movements that we observe.
This 5-step framework seems like a powerful tool. It moves beyond simply labeling the condition and offers a potential neurobiological mechanism. How can we use this framework to answer common patient questions and concerns in the clinic?
It's potentially our greatest asset in that conversation, because it allows us to explain the involuntary nature of the condition in a way that validates the patient's experience. It transforms the diagnosis from a potentially stigmatizing or vague concept into something grounded in understandable brain mechanisms.
So, for instance, explaining the commonality of the disorder, how might we approach that?
We could explain that functional neurological disorder is common, precisely because the underlying mechanism, active inference, the brain constantly making predictions, is the fundamental process the brain uses for everything it does. seeing, feeling, moving, thinking. The symptoms, therefore, can be seen as being on a continuum with everyday experiences like visual illusions or that cup example where prediction goes slightly wrong.
Mm.
It's not some rare psychological failure, but rather a disorder arising from a fundamental, ubiquitous brain process that has gone awry.
What about addressing the trauma link, which can be sensitive but is often relevant?
We can try to explain the pathophysiology directly, perhaps saying something like, significant past adversity or trauma can sometimes leave a kind of limbic scar. It can make the brain's emotional circuits and their connections to motor circuits hyperreactive. This creates a predisposition, a sort of limbic motor fast track. This doesn't mean the current symptom is caused by emotion right now, but it explains why this system might be more vulnerable, allowing emotional or stress-related influences to sometimes unduly hijack the motor system, which could explain why symptoms might emerge or worsen years later, perhaps during periods of increased life stress.
The model also helps explain the diversity of symptoms, the symptom phenotype, how it can be both positive and negative symptoms.
Yes, the theory clarifies why the same underlying mechanism, excessive attention coupled with a strong prior, could theoretically cause both positive phenomena, like a tremor, or abnormal sensations like tingling, and negative phenomena, like functional weakness or numbness. The specific form the symptom takes is largely determined by the content of the specific prior belief that has become dominant. My hand is shaking uncontrollably versus I cannot feel or move my hand. The excessive attention, however, determines the amplification and persistence of that prediction's effect, regardless of whether it's a positive or negative symptom manifestation.
This leads us to arguably the most crucial clinical conversation, distinguishing inconsistency versus feigning. How can we use the model to explain this clearly and non-judgmentally?
This is where the model is incredibly helpful. We can explain directly to the patient. Your symptoms, like the weakness that seems to come and go, are absolutely not feigned or deliberately produced. They are mediated by how your brain is allocating attention. Think of it like that choking athlete analogy. When you consciously focus extremely hard on trying to move your leg, your brain unfortunately overrides its normal, smooth, automatic program, what we call implicit movement, and forces the control into a different, much more effortful, error-prone, explicit program. That's why you might be able to automatically use the leg perfectly well when climbing stairs, but find it impossible to move when I ask you to focus and push against my hand. That difference, that preserved implicit ability when attention is elsewhere, is actually an objective neurological sign, a biomarker confirming the nature of your condition. It's not about effort or willpower. Furthermore, this framework helps us understand the powerful societal and cultural influence often observed on symptom manifestation. Since our prior beliefs are heavily shaped by our experiences, our learning, and the cultural milieu we live in, we sometimes see phenomena that look like mass hysteria or shared symptom beliefs spreading through social networks. The recent example of TikTok tics might fit here.
And it explains why symptoms sometimes don't follow anatomical rules.
Critically, yes. It explains why functional symptoms often reflect common, sometimes widely held, but anatomically incorrect societal predictions or beliefs about how illness should manifest. Think of classic examples like functional visual loss, presenting as sharply demarcated tubular visual fields, or functional sensory loss that splits precisely down the midline of the body patterns that defy the known wiring of the nervous system, but might align with the layperson's prediction of what severe sensory loss would look like.
All of this underscores the immense importance of providing a clear explanation to the patient.
It cannot be overstated. Patient understanding of the underlying mechanism, feeling that their experience is validated and understood biologically, is known to be directly linked to improved engagement in therapy and better prognosis overall. The principles of treatment, therefore, emerge directly from understanding the model.
What are those core principles?
Therapy aims to essentially retrain the predictive brain. This involves strategies to help change or update the fixed prior belief, techniques to distract the maladaptive attentional spotlight away from the symptom towards more functional goals, approaches to reduce avoidance behavior, which limits the brain's exposure to corrected sensory evidence, and crucially, optimizing general allostatic maintenance, improving mood, sleep, nutrition, managing stress to reduce the overall physiological noise and hyperarousal that might be feeding the problematic predictions.
So providing patients with a genuine mechanistic understanding is the foundation.
Yes, validating their experience of involuntariness, perhaps even referencing objective neurological findings like the temporoparietal junction hypoactivity if appropriate, is the foundational step. It moves the conversation away from blame or dismissal and towards guiding them into effective, mechanism-based rehabilitation strategies, often involving multidisciplinary teams.
It seems the ultimate goal of treatment, then, is to challenge the brain's currently constructed reality.
You can frame it that way. We are fundamentally aiming to introduce new, compelling sensory evidence through movement, through graded exposure, through cognitive reframing that is assigned high enough precision by the brain to finally force the system to update that entrenched, maladaptive prior prediction of illness.
It's a fascinating perspective, the idea that a patient's prior belief about their own body and illness is, in a very real sense, generating their perceived reality.
And therapeutic success hinges on helping the brain rewrite that internal script based on new learning and experience.
We certainly hope this deep dive into the active inference model provides you, our listeners, with a more concrete, actionable framework for improving both your understanding and your communication around functional neurological disorder in your clinical practice.
And just to reiterate, this summary is based strictly on the source material we reviewed and is intended for educational purposes for neurologists. We strongly encourage all listeners to seek out and read the further readings suggested in the original paper for a fully comprehensive picture.
Thank you for participating in this deep dive.
Join us again next time for the weekly Neurology Deep Dive, produced by Amer Gavanini.